Jenny's medical background includes 3 years of chronic left hip pain, which has been diagnosed as osteoarthritis. This correlates with Jenny reporting difficulty in activities of daily living, such as getting up from a chair, bending down, going upstairs, and stiffness in the mornings. Additionally, Jenny also has bilateral plantar fasciitis, which has affected her ability with walking for long periods. These conditions relate to the need for commencing a rehabilitation program, as Jenny aims to delay or avoid a total hip replacement surgery, improve quality of movements of daily living, and reduce pain. Without intervention, these conditions can further deteriorate and lead to various impacts in her life. Hip osteoarthritis is a progressive and degenerative condition of the joint and is commonly associated with individuals with high sedentary behavior, obesity, and aging populations. The pathophysiology of the condition includes the degeneration of articular cartilage between the femoral head and acetabulum, resulting in bone remodeling, inflammation, and dysfunction. Outcomes include muscle atrophy or weakness of the hip complex, which further affects joint stability, production of peak joint forces, joint range of motion, and protective reflexes. In correlation to Jenny's case, her functional capacity was greatly affected as she reported difficulty in performing tasks. These are common symptoms and dysfunctions associated with hip OA, as individuals will experience greater amounts of pain or stiffness during and after completing task. The plantar fascia originates from the postmedial calcaneal tuberosity and is inserted into each metatarsal head to create the longitudinal arch of the foot. Plantar fasciitis is an overuse condition causing deterioration to its attachment site at the calcaneus and inflammatory responses. Localized pain is generally experienced in the morning around the proximal medial plantar surface of the foot and can further worsen throughout the day. In correlation to Jenny's case, she commonly experiences pain in both feet after walking for long periods of time, causing a debilitating effect. Clear correlations can be made between the client's presentations, their current pathologies, and the results from their physical assessments, as key defects are identified. Range of motion measures for hip external internal rotation, flexion and extension, and abduction all presented moderate to high defects in comparison to limb symmetry or normal data. Additionally, manual muscle testing also indicated defects in muscle strength with scores of 3 out of 5. Jenny's left side was fairly weak in abduction, extension, external rotation, and ankle inversion. These results correlate to Jenny's pathology of hip OA, where it is common for individuals in the hip complex to have limited range of motion, joint pain, and weakened muscles in these actions. These also associates with Jenny's presentations and performance in some of the functional testing, where compensatory efforts such as excessive trunk movement, Trendelenburg signs, and instabilities were recognized. This slide presents relative short, mid, and long-term rehabilitation goals that the client and practitioner can have for the client's rehab process. In correlation to the client's condition, goals will focus on gradual targets for the improvement of range of motion and strength of the hip, which in turn aids in improving ADLs, reducing pain, and delaying or avoiding total hip surgery. Additionally, specific long-term goals such as achieving within 10% asymmetry in range of motion and strength in the hip and ankle, or reducing weight can also aid in creating clear targets to reach. Overarching goals can also aid the client holistically and may include providing education to the client, as research has shown it can improve adherence and understanding of the severity of the condition and importance of the rehab process. Safety considerations are vital in ensuring both the client and practitioner are safe, preventing further injury, and promoting a safe gym environment. In correlation to Jenny's case, due to her current physical state, conditions, and knowledge of the gym, safety precautions are required. Throughout the session, essential factors to monitor include client symptoms of pain or stiffness, exercise technique, and the intensity of each exercise. These factors can be addressed through exercise progressions and regressions to ensure the client is performing exercise safely and correctly and within a reasonable workload. and reduces the risk of further damage to their pathologies. Additionally, the VAS pain monitoring score can be utilized as a safety precaution tool to identify if the exercise is causing excessive pain. Research has indicated if scores exceed a 4 or 5 out of 10, it is recommended to either modify or stop continuing the exercise. Other safety considerations include the client being a falls risk, the cleanliness of the gym, and the client having low confidence. Jenny's initial session includes an adequate warm-up and cool-down sequence. As research has shown, this is essential in properly preparing and mobilizing the body for the intended workload, and post-exercising gradually returning to a resting state safely. Following various literature, warm-up and cool-down protocols, inclusion of a cardiovascular-based exercise as well as stretching has been shown to be successful in older age populations in reducing risk of injury and pre- and post-exercise monitoring of the client. Both sections included walking on the treadmill as the client enjoys this exercise and has been one of her long-term goals to return to prolonged walking. Additionally, stretches were focused on improving mobility in the hip complex and ankle, as due to her hip OA, plantar fasciitis, and assessment results, as the client presents as having tight muscles and limited range of motion. Current literature such as the GLAD program, ACSM guidelines, and other resources aided in the inclusion of specific exercise selection for the program, as exercises were categorized into sections such as functional, isolated, and balance. Jenny's hip OA defects were identified in her initial assessment in hip strength, range of motion, pain level, and overall technique. Additionally, Jenny's ADLs, such as getting up from a seated position and going upstairs, were reported to be difficult to complete regularly. Therefore, bodyweight sit-to-stands and step-ups were selected to address exercise technique errors, such as compensation efforts and excessive trunk movement, as well as improve hip flexion, extension, and stabilization in AB and AD adduction. In correlation to desired outcomes, these exercises can aid in achieving greater range of motion and strength measures with closer asymmetry to either side and assist in delaying and avoiding surgery. The isolated hip exercises addresses weakness in hip AB, AD adduction, and extension, as common hip OA presentations indicate global weakness in the hip complex. These exercises can aid Jenny in the stabilization of the hip during movements such as walking and squatting and reduce sensation of muscle tightness and pain. Bodyweight standing calf raises were also selected due to Jenny's bilateral plantar fasciitis, as through the gradual eccentric loading and lengthening of the plantar fascia and improvement ankle stability and balance. By gradually improving Jenny's ankle stability and relieving pain, this can help her to return to walking for long periods of time and continue with her ADLs throughout the day. Lastly, a single leg foam balance exercise was included to address compensation efforts, lower limb balance, and trunk strength to reduce excessive movement. In Jenny's assessments, there were clear weakness identified between either side balance, as well as a lack of confidence from Jenny to perform more advanced balance exercises. Following the ASM guidelines and additional literature, the workload of the exercise was kept to 3 sets of 8 to 10 reps, with an RPE ranging between 10 to 12. These low to moderate intensities ensured Jenny's safety, limit provoking her conditions, and sudden onset of pain. Progressions in Jenny's exercise plan can be established once certain criteria and milestones are met. This ensures appropriate workload is managed, limit risk of further injury, and gradual advancement in rehabilitation is achieved. A variety of objective and subjective indicators can aid in the identification on when and how to progress Jenny throughout the stages of rehab. After the initial stage, progression indicators would be Jenny's ability to perform exercises with low levels or without pain, greater range of motion with gradual closer measurements in asymmetry, and improved exercise technique and confidence. These progressions promote the transition into the intermediate stage of rehab, where exercise progressions may include introducing greater resistance using resistance bands or machines, removing assisting tools such as the wall or pole to aid balance, introducing new functional exercises, or additional exercise sessions outside of the clinic such as aerobic specific or home-based. These exercise progressions align with Jenny's short and mid-term goals of addressing defects in range of motion and strength, receiving education around exercising with her condition, and managing pain. Following the intermediate phase, further progression indicators can include strength and range of motion near 10% asymmetry, greater overall performance or client readiness, improved functional exercise techniques, and reported lower difficulty in ADLs. In the later advanced rehab phase, progressions can include the complexity of the exercise. An example of this could be a step up into a triple extension or single leg balance on a foam with eyes closed. Additionally, the resistance and intensity, such as the number of sets and reps completed, or eccentric tempos, can be modified for greater challenges. With continuation of progression in Jenny's program, this can further support her long-term goals of avoiding surgery, returning to walking, reducing weakness, pain, and weight, and the less difficulties in ADLs.